Welcome to the Drip Podcast, hosted by myself, Angela Craig. I am an advanced practice nurse, a clinical nurse specialist, and a senior medical manager with medical affairs at Baxter. DRIP standing for D, define, R, research, I, innovate, and P, practice. It embodies a patient centered, evidence based approach for cutting edge medical science. Our mission is to foster scientific discussions with the brightest minds in emergency and critical care, with a never ending ambition to save and sustain lives. Join us as we navigate through topics like fluid management, fluid choice, and shock resuscitation. This podcast is part of a non-promotional education series. Our guest has been compensated for their time and participation today.
Hello and welcome to the Drip Podcast. Our guest today is a highly accomplished intensivist who serves as the medical director of the cardiac and cardiothoracic intensive care units at Baptist Medical Center in Jacksonville, Florida, providing leadership in the ICU and contributing to numerous committees aimed at advancing patient care and clinical practice. Dr. Eddy Joe Gutierrez holds a Doctor of Medicine and Surgery degree from Universidad Latina de Costa Rica and completed a rigorous residency in internal medicine at Memorial Health University Medical Center in Savannah, Georgia, where he was recognized as Chief Resident and Resident of the Year. He is board certified in internal medicine and critical care by the American Board of Internal Medicine. Fluent in both English and Spanish, he is dedicated to advancing clinical excellence, education, and innovation in critical care medicine. Please welcome Dr. Eddy Joe Gutierrez.
Hello, everyone. This is going to be a great podcast today. I am your host, Angela Craig. I am a senior manager with Baxter Medical Affairs, and I have Dr. Eddy Joe Gutierrez here with us. So, Dr. Eddy Joe, welcome. Tell us, though, how you want us to. Is Dr. Eddy Joe appropriate, or you've kind of got a little social media name out there as well?
Yeah, the you can just call me Eddie. That's what everybody calls me. The Eddie Joe is a family name, and I just decided to use it as a way to differentiate myself from every other Eddie in the world. And my last name being Gutierrez is a little bit challenging for some people to say, so therefore the Eddie Joe works fine or Eddie works fine. I always joke with my patients who struggle with my last name. I just, hey, my mom calls me Eddie, so you could call me Eddie too, and that usually eases them a little bit from the pressure of trying to have to say Gutierrez.
Aw, that's nice. In fact, that kind of just brings me to I want to talk about your book. I have your book in my hand right here. And I remember in a previous podcast that we did on research and publishing, is this even a possibility or a dream? It was a previous a recording. I read a quote from your book, from the book called The Vasopressor and Inotropic Handbook. And it's a practical guide for healthcare professionals. I definitely encourage people to pick this up. This really wasn't here to be your big sales pitch, but I'll do a little sales pitch for you because I do think anything that we can read that helps the nurse at the bedside, the doctor at the bedside. In fact, I think I gave a copy to my son who's in residency now.
Oh
So I'm like,
wow.
read this book. Um, but there was a quote that you said, "You're just so humble," and just like you told your patient to call you Eddie. This statement really resonated with me, and I've never told you that personally, but it did. And it says this: "I extend my deepest gratitude to everyone whose work is cited here. Your contribution to the families of patients who participated in these clinical trials is invaluable. I offer my heartfelt thanks to the unsung heroes on the research teams, often working tirelessly behind the scenes without public acknowledgement. Thank you to the bedside nurses and pharmacists who meticulously prepare and administer these critical medications. Your role is vital in the seamless execution of these studies and our daily management of patients." And then you go on to say if you forgot somebody else that you were sorry or whatever, that it takes a team. And that's what I really like about you, that you really are focused on the team, and we all need to get it right, right?
Absolutely. Absolutely. And it is true when you go ahead and you read any of these articles, the data that we're going to discuss hopefully today, discussing fluid responsiveness, there you see the name of the 6 to 18 or sometimes 45 authors on that study, many of which did not much outside of just share an office with somebody. But the reality is that the researchers in the background, those men and women who collaborate to enrolling patients, processing the
Oh,
data, all that, those folks are never mentioned in any of the papers. In addition to that, as I mentioned, I was a PI in several clinical trials, and the ones who did most of the hard work were my nursing staff with
yeah.
administering the drugs, looking for the adverse reactions, all those things. And they didn't get any name recognition on the papers or anything like that. So I just wanted to really acknowledge that, because even though my book cites over 500 different peer-reviewed medical articles, the reality is that there's tens of thousands of people who
Oh, so
contributed to
true.
those combined who you'll never know about them.
That's
And then
so
from a
true.
family perspective, I'm not in a at a major medical research institution right now. I'm at a community practice, which I prefer. But when I was doing my fellowship, we enrolled a lot of patients into different clinical trials, and their families would just hoping that this would be what turned their loved one around, whatever intervention we were trying. And that adds complexity to the issue that already makes them critically ill. So they're
Yes.
like, "Oh, they're critically ill, they're already on life support, that's why we're their doctors and nurses and RTs, pharmacists, etcetera." But in addition to that, we're also throwing in a potential confounder into their treatment, which could potentially be some hopeful thing or a placebo. And so
Right.
it's something that not a lot of folks think about, but,
Yeah.
I just
Yeah.
wanted to acknowledge that as I
Yeah.
was putting that together.
I love that. I love that. Well, what makes you wake up someday and say, I want to write a book about vasopressors and inotropes?
So it's actually pretty convoluted story, but um when one is going through their residency and fellowship, you're always preparing presentations, preparing grand rounds, etc. And I'm the type of guy who likes to do a very deep, thorough research into every topic that involves critical care. Well, I already had of the 500 plus articles, I probably already had around 250 that I had already read on my free time without the intention to ever writing a book, anything like that. And then one day I said, I'm gonna potentially write a book. I wrote out the table of contents, but you know, we put it in the back burner. We're busy with this, that, the other. But I hope I don't. I've shared this information before with Nicole Kupchik, who is a critical care nurse and
She's
does a lot of
amazing.
nursing education. Amazing, amazing woman.
Yes.
She cold called me one day on my cell phone, and my cell phone rings. It says Nicole Kupchik. I'm like, is she okay? Is this a butt dial? Why is she calling me in the afternoon? And she says, Eddie, what's your address? And I go, well, why do you want my address? And she goes, because I wrote a new book and I want to send you some copies for your nurses. And I go, Nicole, like, I want to support you. I'll buy the books and, I'll support your business and whatnot. And she goes, no, you don't understand. I got a lot of the information from your website. And from and I'm like, "Oh, that's really neat you did that, like, that's cool." And we talked about it. She sent over a bunch of books for my nursing staff, and that's all sitting in the nurse manager's offices. But she concluded the conversation, she's like, "Eddie, you really need to sit down and just write a book about all these things that you're doing." And I said, "Well, I don't have time, this, that, the other," the excuses that we all have, life is too busy. And then once I hung up the phone, I said, "I actually just got to do this." And so I
Yeah.
sat down and I focused on it and I knocked it out.
That's
Now,
amazing.
I've
I
never
l
I'm not an author. English is my second language. Grammarly helped me out incredibly. Paying editors helped me out incredibly so that it actually made sense. My wife read the first couple drafts and she's like, "This is terrible. Nobody's gonna read this." And she was right. It was really, really bad. Uh, but it ended up working out well, and I'm thrilled that the reception has been what it's been.
Yes, that's awesome. That's great. Well, I met you at a conference. Actually, Nicole's who introduced me to you years ago. So I think we were at a Society of Critical Care conference, or maybe it was an NTI. I can't remember, but one of the conferences. And then I was able to order your book, and I think you had one for me, but I missed you, and you were heading back to the
Mhm.
airport, so I got mine. So it is available on Amazon for anybody who's asking. But really, I just wanted to talk about some of the literature, and I've been doing some homework and listening to some of your podcasts and reading your book, etc. So we can talk about fluid responsiveness at some point, but what does the literature say when it comes to what is the best sensitivity and specificity for getting fluid right? Is there a one size fits all, or is there really kind of a variety of things that we do to make the right decisions?
I am a huge fan of individualized care. I don't like cookie cutter medicine because it doesn't work for everybody. Starting even with the fact of fluid responsiveness itself, we have to understand that there's limitations to all of our technologies, all of our strategies. Heck, even our own blood pressure cuffs have limitations to them. So when you think about a patient who's critically ill and your first inclination is to give them fluids, you want to make sure that that it counts. You want to make sure that it does actually change the stroke volume, that it does improve the cardiac output, because that's the whole purpose of giving fluids in the first place,
That's
is
right.
to give the fluid to see a result, not give fluids. And I always say this, but it's not give fluids just to follow the 30 cc's per kilogram protocol that the Society of Critical Care that CMS makes us do, and the surviving sepsis guidelines say and all that, because that's not going to work for everybody, and that's been demonstrated in several studies. But hey, I'm not here to tell the government how to do their job. They are here to try to tell me how to do my job, but that's a different conversation.
For a different
um,
podcast.
but yeah, different podcasts. But the reality is that fluid responsiveness is the best way that we know of at this moment, at this day. It's 2025. It's August of 20. It's August, correct? I
Yes,
feel
it
like I
is.
have to do my check my orientation questions. But it is the best way that we have to determine whether somebody should benefit from fluids. I use the word should because we also have to consider fluid tolerance. There are
Mhm.
some people who are very wet, they're overloaded. You do an ultrasound on them, they have B lines. They probably won't benefit from having more fluids, but at the same time, they would be fluid responsive. So that's
Okay.
why every patient needs to be evaluated as an individual before making a clear-cut recommendation as to what one should do. Now,
Mhm.
that being said, medicine is filled with statistics, and they have done numerous studies. And I hate to say this to my bedside nurse friends, but the reality is that the passive leg raise is the way to go, as it is the gold standard for fluid responsiveness with the highest sensitivity and specificity. I know there's
It
a lot of people
really
doing like
is.
this right now, but it really is the best way to assess for fluid responsiveness.
It really is. And I love it from the standpoint that, make that nurse driven, and then nurses can come to you with more scientific data, whether the patient is fluid responsive or not, based on what they're dealing with. And I just think in order for us to be more scientific in dialogue, if nothing else, right?
Sure.
What about I've heard of people before doing passive leg raises with blood pressure, and that always kind of baffled me because I don't think the sensitivity and specificity is there, but I think people like to think they're doing a passive leg raise and that counts. Does that count in your mind?
So this is actually very entertaining to me because when I was a baby doctor, back when I was a fellow and I had the chance to actually read all this literature, I used to go to the bedside, there goes
Yep.
little baby Dr. Eddie walking over there to the bedside. Oh, the patient's hypotensive. I used to just pick up their legs, and if the blood pressure went up, I said, oh, this patient needs more fluids. Give myself a pat in the back. People looked at me like, oh, he knows what he's doing. Look what he just did. But the reality is that that's wrong. Baby Eddie was not that smart. He thought he was smart. So the data when it comes to looking at passive leg raise by looking at the blood pressure, not looking at cardiac output, cardiac index, stroke volume, any of those things. Just looking at blood pressure is about a coin flip. I don't have the paper in front of me to actually give the statistics, but I think the area under the receiver operating curve is about zero point 0.5, which at the end of the day is guesswork. It's a coin flip. It doesn't really signify anything.
Yeah. And you were talking about it resonated with me when you said, things could change in 15 minutes. I at times am mortified for how I used to teach, but the reality was back then that's what the standard was. But things changed, but I still feel do you still kind of think and you're like, "Oh, I can't believe I told him to do that." But back then that is what was right. So you're exactly
Mhm.
correct. I feel like we have to be open to change. We have to be open to the latest literature. We need to know the latest literature so we're not teaching what's, not appropriate.
Absolutely, and to your point, I trained under the Manny Rivers protocols that I shriek at the idea of giving somebody 5 liters of fluid trying to get their CVP up.
Yeah. Yeah.
Those were different days.
Those were different days, and we've learned that there is, an increase in mortality with fluid overload, so we
Yeah.
don't wanna take that lightly. But he is a great man too. One of my, friends, what a he really led us to, looking at this and taking a deep dive into protocolize or
Mhm.
really looking at it, and I wouldn't say necessarily just protocolize, but now it's kind of evolved to individualized patient care.
Right.
And so
Well,
he's
but
taught us a lot over the years, that's for sure.
absolutely, and again, I don't want to make it seem as if I'm poo-pooing of sorts on Manny Rivers because that was something that was game changing with improvements in mortality based on those data. It's
Yeah,
just that 20 years later, things are a little bit different, and thankfully
absolutely.
so, right? Because one would just hope that we would just keep on getting better.
Yes. No, I definitely agree. What about, on that same kind of topic when we talked about, fluid, responsiveness, what about with end-tidal CO2? Have you ever done it with end-tidal CO2?
So the short answer is no, I haven't done it, but I have looked through the literature, and the reality is that if you have a patient who has a stable rate on their mechanical ventilation, if you could find a way to increase their cardiac output, you are going to see an increase in the CO2 that's coming out of their lungs. So
Yeah.
therefore, they're if the patient is fluid responsive, in other words, you give them fluids, it's going to increase the cardiac output, it's going to
It should
increase
increase
the
the
end-tidal CO2, and therefore you're going to be able to get a good response on that. Some advantages of it is include the fact that you don't need a device or something like that, just capnography. If the patient has a metabolic rate that's high or a metabolic rate that's variable, that might be a limitation. If the patient has a lot of dead space, that could cause an issue too. So, it's not as robust when it comes to the literature compared to some other ways of assessing for changes in stroke volume or changes in cardiac output or cardiac index, but it is something that is worthwhile.
Yeah, and I just think of sometimes maybe some of the underserved areas that don't have technology, maybe
Mhm.
that's something they could look at, but I'm not sure if they don't have the other technology, if they all have entitled CO2, but something to think about. And I think, speaking of how we used to educate years ago, I think of like stroke volume variation. Back in the day, we thought that was the best thing ever, right? And then we realized there are a lot of limitations to looking at stroke volume variation in the ICU particularly, right?
Mhm.
Um, Maybe in the OR you have some more, some of those like 8 mils per kg of tidal volume or the can't be spontaneously breathing, things like that. So maybe it's more appropriate or have you changed your practice? Did you ever used to use stroke volume variation?
So the short answer, yes, I used to use for volume variation quite a bit. Actually, throughout the whole course of my career, including my residency. Now, I didn't know the limitations at first, but those got filled in little by little. The reality is that I do use, for example, stroke volume variation as well as pulse pressure variation pretty much every day. And I do not work in an operating room. I work in ICU, but where I use this technology is in patients who come up after open heart surgery because
Mhm.
the anesthesiologist put everybody on a higher than 4 to 6 cc per kilogram of ideal body weight rate. Everybody comes up paralyzed. Most people are in some sort of sinus rhythm, and therefore it's a little bit easier to use this technology the way that it's designed, and more importantly, the way it's validated.
Yeah. Yeah. So, Dr. Eddy, do you have any practical applications that you can share with us? How do you feel like, as we look at stroke volume changes, as we think about changes in cardiac output and stroke volume related to volume, what about the rapid response team? Have you had any experience with that, or what are your thoughts? I know there was a fairly recent article that came out that was talking about the benefits of utilizing something like that in rapid response. I didn't know if you had any thoughts about that.
Sure. So I feel bad for my rapid response team because
You put a
something
lot
that
of pressure on 'em.
it is a lot of pressure to try to decipher what's going on with the patient, what's going to be the best course of action, or even for that matter, which ICU to park them in. Is it going to
Sure.
be a cardiac ICU or is it going to be a medical ICU? 'Cause
Mhm.
and where I have a cheat sheet of sorts is I could put a probe on somebody's chest and do a quick echocardiogram and assess what the function is of the heart, and I have my answer within a couple seconds, versus my rapid response team, well, they don't. And it also depends what technologies exist in different hospitals to hopefully help out the patient.
Yeah, correct. Using what you have, and there are those non-invasive, abilities out there, so I've heard of some rapid responses really having some benefit. Being able to really help decipher, like, are they fluid responsive? Do they just if they're a little hypotensive on the floor and we're running tight on ICU beds, maybe we can give them some fluid and they can stay on the floor, but then have, recheck to make sure they're doing alright. I just think that's a great might be a great opportunity, for the
Absolutely.
future.
Or
So
or even my favorite rapid response is the ones that are on patients who live with a mean arterial pressure of 60 or even 55 for that matter. And you go to assess them and they look fantastic. And they're talking to you and like, like, is this just where you live? And then you talk to them a little bit and you find that they're on Metadrin and things of that nature.
exactly, exactly. So knowing that patient, that historical information is so important as well because who knows, they could end up in the ICU on pressors when they maybe don't warrant that. That's a good point. Well, tell us this, any final words for us? What any good books you've read or any good articles that you would recommend for us?
Well, that's a tough question. I do have to recommend the vasopressor. No, I'm just kidding. Mhm.
That's right, I've got it right here too. Woohoo.
but one of the things that I do to make sure to stay up to date with everything that's coming out of medicine, because we all see too many people who graduate their or complete their fellowship, and that's kind of where they stay from a literature standpoint. I personally like to review articles every single morning. I subscribe to all the table of contents of all the major journals involved with critical care, cardiology, cardiothoracic surgery, etc., to just peruse through the abstracts and see what's coming out there. And if there's something that piques my interest, then I just go down that rabbit hole. And then 6 hours later, I learn maybe something that a whole new world that changes my whole worldview of how to manage a certain pathology. From a reading books for fun standpoint, I haven't done that in a long time.
Your fun is your research articles, right?
It is, not to mention that I'm working on a different type of book right now, so
Well, there you
I
go.
am consumed entirely with knocking that out.
Good for you. Well, you'll be have to come back with your next book and we'll chat about it, but it's really great to chat with you and I know that you have a podcast too that I've listened to before. So maybe as we're leaving today, you can just share if somebody has heard this podcast here today and wants to hear more from you or has a question for you, how might they be able to reach out to you?
Sure. I mean, quite frankly, you could just email me, eddyjoemd@gmail.com. That's a very easy way to get a hold of me. And, we all live with our phones on top of us. We answer emails from people who have purchased copies of the book or given feedback or whatever. The other thing is that on all my different social media accounts, there are ways to message me. And I do check those messages, even though I do have a timer where after 20 minutes of being on social media, it gets cut out. I can't stay on social media more than 20 minutes per day.
Oh my goodness. Well, so on social media, just share with us a few of the ways that we can reach out to you on social media or listen to you on
Sure.
social media.
Absolutely. So under the handle Eddy Joe MD, which is with a Y, not with an IE, EDDYJOEMD, I am primarily on Instagram. That's where I've been since 2017, creating a significant amount of content. I'm also on X, LinkedIn, Threads. Uh, where else am I? And I'm also on TikTok, although I just haven't had the opportunity to create dedicated content there. I know that that's an ever expanding platform. I just haven't found my way into creating content that resonates with the audience there. But that's something that is on my very long to-do list that I think I'll never accomplish.
Well, keep growing, keep learning, keep teaching us. We really do appreciate you and really thankful you came on today's podcast with me.
Well, thank you for having me. It's great to chat with you again.
Yes.
As we conclude today's episode, I remind our esteemed medical colleagues that the opinions expressed herein are solely intended for professional discussion and should not be construed as medical advice. We encourage all listeners to consult their own healthcare providers for personalized medical guidance.